Hello ladies and gentlemen, this is Helge Alexy from the Cardiology Forum, and today I welcome you to the next episode of our STEMI Pulse series. This is the part 2 where I present you an additional very interesting STEMI case. What brings us to the third STEMI case I brought to you, and this is a completely different ECG pattern. You already noticed it's a left bundle branch block, and if we have this ECG pattern, the STEMI guidelines tell us new onset of bundle branch blocks can be treated as STEMI, but very many of us are very conservative if we see bundle branch blocks in patients, because we all know lots of patients have these ECG patterns for months or years even, but this can encode for an acute myocardial infarction as well, and we need to recognize when that's only a normal left bundle branch block and when there hides a STEMI behind that. And to recognize that and to evaluate the patient for STEMI and getting to the cath lab earlier, there are some criteria. And you already know what I'm talking about. I'm talking about the SGARBOSSA criteria. And the SGARBOSSA criteria help us to diagnose a STEMI pattern in the presence of a left bundle branch block. There are 3 criteria. And the first one is you look in any of the ECG leads for a concordant, means positive or in the same direction pointing, QRS complex, ST elevation positive, and T wave positive. If there is a concordant ST elevation of 0.1 millivolts or 1 millimeters in any of the leads, there is a positive SGARBOSSA criteria. The next pattern is a discordant ST elevation, means a very prominent S wave in the QRS complex, and then a ST elevation of 0.5 millivolts or 5 millimeters in any of the leads, a discordant ST elevation of 5 millimeters or 0.5 millivolts in any lead. And the third criterion would be a concordant ST depression. Concordant ST depression, concordant to a very deep S wave, ST depression of 0.1 millivolts or 1 millimeters in one of the leads, V1, V2 or V3. There is a modification of the SGARBOSSA criteria that is done by Smith et al. And in these modified SGARBOSSA criteria, there are only little changes, but that pushes the sensitivity from 52% to 91%, but decreases the specificity from 98% to 90%. But there are much less false negative. You almost got all of the STEMI diagnosis with the modified SGARBOSSA criteria. And there's only a little change. The change is that you are looking in any of the leads, not for the 5 millimeter threshold, but for a concordant ST elevation of 25% of the preceding S wave. 25%. Now let's have a look at our patient's case if one of these criteria are positive here. These are the criteria again, and if we have a look at the chest, at the limb leads, we don't have any of these criteria positive here. There is no concordant ST elevation, there is no discordant ST elevation that is after a preceding very deep S wave, and the third criteria is only for V1, V2 or V3. But if we have a look at the chest wall leads, then it's getting exciting. We have a discordant ST elevation here. Deep S wave, splitted S wave, and then a very huge ST elevation here, discordant to the preceding S wave. And do we have the original or modified SGARBOSSA criteria positive here? We do. We have a ST elevation of more than 5 millimeters, 0.5 millivolts, about 0.7. And we have about 1.6, 1.7 millivolts S wave depth, and that is more than 25%, more than 30% of ST elevation in contrast to the preceding S wave. So this one is a positive SGARBOSSA criteria. Let's have a further look. If we have this one positive in V1, V2 or V3, no we don't. We don't have ST depressions here. But what we have also is the first SGARBOSSA criteria. This first SGARBOSSA criteria is a concordant ST elevation in one of the leads, in one of the ECG leads. And in V6, we have a ST elevation of 0.1 millivolts, 1 millimeter ST elevation in V6. So we have two, it's very subtle and on the edge of being positive, but I think we can call it a positive SGARBOSSA criteria in V6. But one positive criteria already is enough due to the modified SGARBOSSA criteria to call this ECG pattern STEMI. So let's have a look what we found. What we found in the coronary angiogram is an occluded LAD. An occluded LAD. The LAD should go down here in a cranial view. This is a septal branch. This is the D1, and these are the LCX and the marginal branches. This is an occluded LAD. And you see it here as well on the spider view, occluded LAD. And after revascularization, after the PCI, you see this big vessel going down here till the apex of the heart, of the left ventricle. And if we have a patient with extended anterior wall myocardial infarction like this patient had, and he came to us after 3 days of chest pain already, 3 days of chest pain till he got to us to the emergency department and then to the cath lab, we always perform a echo with contrast, with the giving of dye, to exclude a LV apex thrombus, because 5% of the patients with an anterior myocardial infarction develop a thrombus in the LV apex. And if you don't give dye in these patients, contrast in these patients, it's very likely that you oversee these thrombi in the LV apex. And this is the echo we performed at the patient. You see there's an akinesia in the apex, a scar there. And if you tilt the probe a little bit different, you already see some disturbances there in the apex. Then you see a thrombus formation in the LV apex. So this patient developed through the contractility disturbances in the apex a LV thrombus. And that is very important because it has therapeutic modifications for the patient. He must be on anticoagulation till then. And we also performed a 3D echo and could visualize this thrombus. Here we are looking from the septal part to the lateral apical part, and we see some trabeculations of the myocardium here, and this is the clot formation. And this is another view where we are looking from the basal part of the LV to the apex, and there you see this thrombus formation as well. So thank you for watching this video. I hope you liked it, and if you did so, subscribe to the channel, give us your thumbs up. Yours Helge Alexy, bye bye.